You're listening to Clinical Conversations, a Journal Watch podcast. It's for the week ending September 18, and it's podcast number 57. I'm Joe Elia, and I have a favor to ask of you. Clinical Conversations needs your thoughts and opinions. Please visit our webpage at podcasts.jwatch.org to take a brief survey. If you complete the survey by October 3rd, you will receive a $5 Amazon.com gift card. The gift card will be sent to your email address, and for some reason, we'll need you to allow up to 2 weeks for delivery. Please see our website for details. Again, that's podcasts.jwatch, JWATCH.org. Thank you in advance for giving us a piece of your mind. This week's conversation is about using guideline-compliant empirical therapy in community-acquired pneumonia. First, a look at the week's principal clinical news. Haemophilus influenzae B vaccine recommendations have been slightly changed by the Centers for Disease Control now that Hiberix is available. Hiberix has been approved for use as the booster dose for children aged 15 months through 4 years who have received the primary series of 2 or 3 shots, depending on the formulation. Now, Hiberix and other conjugate vaccines can be given as early as 12 months to facilitate timelier booster shots. If Hiberix is given inadvertently, though, the dose should be counted as valid and need not be repeated. Got all that? If not, there's a link to the details in MMWR, which you'll find on our website, podcasts.jwatch.org. The other important story of the week, besides the one we're about to have a conversation about, was the announcement of a boxed warning for the sedative and antiemetic promethazine hydrochloride. The FDA says that intramuscular injection is preferred because intra-arterial or subcutaneous injection can cause gangrene and other serious tissue injuries. Intravenous use should be done only with limited drug concentrations and slower administration. Now, on to the interview. Last week, the Archives of Internal Medicine had 2 papers on using guideline-based therapy in cases of community-acquired pneumonia, or CAP. One paper focused on elderly patients with CAP and did a retrospective look at whether their care, which occurred in the earlier years of this decade, was compliant with the 2007 guidelines. The other paper focused on adults and did the same retrospective look for compliance with the guidelines. In both instances, guideline compliance was associated with less hospital mortality, shorter length of hospital stay, and other advantages. Here to talk with us about why guideline-directed empirical therapy works are the 2 studies' 2 principal authors, Drs. Forrest Arnold and David Fissman. Dr. Arnold is in the Division of Infectious Disease at the University of Louisville, and Dr. Fissman is at the Dalla Lana School of Public Health at the University of Toronto. Thank you both for talking with us today.
Oh, thank you.
Thank you.
It struck me as odd that both of you would examine compliance with guidelines that hadn't even been issued yet officially. Were you trying to get a kind of a neutral standpoint on how effective the guidelines might be?
Forrest, would you like to go first?
Go ahead, and I'll follow.
All right. Well, this project actually grew out of a conversation with a student, Caitlin McCabe, who is the
first author
on the paper, about antibiotic safety, the question of whether some antibiotics might result independently in harm to patients' antibiotic classes. We were thinking in particular there had been some recent information published about the antimicrobial cefepime, and we were also discussing the use of aminoglycosides in individuals with community-acquired pneumonia. And we realized that we had data available to answer this question thanks to a long-standing quality improvement initiative that's been run by Tenet Healthcare, which allowed us to do this study. So initially, we were thinking about looking at safety of antimicrobials, and then with a lot of the buzz more recently about indicators for clinical performance and some of the controversy about whether or not compliance with guidelines might serve as a good indicator of clinician performance, the project really evolved into something much larger in terms of looking at whether or not compliance with issued guidelines might be associated with improved outcomes or not.
For us, this is Forrest Arnold. Everybody knows to have strong statistics, you need high numbers, and there's two ways to approach that. Certainly one way is the way Dr. Fistman did, was to get a large database with his had over 50,000 people, and the other way is to record people as they have their pneumonia, which is what we have done. And then it's a more relevant question, I think, what happened according to the 2007 guidelines. And to answer that question now, in order to accumulate a significant number of patients, it would take years, or you'd have to have a remarkable number of institutions. And even with over 40 institutions, we just now have 5,000 patients in our database. And so we were able to take the 1,700 or so elderly patients from that and generate meaningful information.
Dr. Arnold, you're part of the what's called the CAPO organization?
CAPO, right.
So it's
the Italians like that, I think.
Really?
Is it the Capo Tutti Capi, or it's just Capo?
It's just Capo. It was created in the United States. We do have Italian members, and they thought it was funny, but anyway.
Yeah. So you prospectively, in those years, you prospectively were just recording the care of...
Some prospective, some retrospective.
Okay.
And that's mainly because this is an unfunded study, and people do it when they have time, and some institutions have more resources, and they have people that can do it prospectively, and others not.
So you were, both of you, interested in, all right, so how good are these, how can we... Or maybe what you were trying to do is and you describe what you were trying to do in the paper, but I'm thinking before you sat down to write the paper, you were interested in how good are these guidelines and what happens when people follow them. And because as you say, Dr. Arnold, if you tried to do that prospectively, it would take years, but now you've got guidelines and you've got data on patients from earlier in the decade when all these drugs were available. And so you're able to to take a look, right?
Right. One benefit was the guidelines didn't change very much from the previous ones to 2007.
Uh-huh.
And so a lot of the approaches that physicians were already doing were according to the 2007 guidelines.
The 2007 guidelines were issued for the first time by two organizations, the Infectious Disease Society of America and the Thoracic,
American Thoracic Society, right.
Right, the American Thoracic Society. Right. So these are now, this is a single set of guidelines for the first time. They were issued in 2007, and so you were looking at that. And so, Dr. Arnold, how big were the advantages, if you would describe them, of compliance among the elderly? Because you looked at people 65 and older, or older than 65, I think.
Right. The biggest advantage was seen probably in the mortality. Mortality difference was about 18% versus 8%. And here with CAPO, we have been tracking time to clinical stability, which is not a common outcome, but it is relevant in the sense that you want to know how much quicker somebody can get better. And if I could have a regimen that would get my grandmother better 24 hours, 48 hours sooner, then that's the one I would want. So we had three, basically: time to clinical stability, length of stay, and mortality.
Mm-hmm. And speaking of grandmothers, it's interesting now that the debate about healthcare reform is happening, and one of the things, of course, is that that some talk show hosts are saying is how's this going to affect your grandmother? And so, at any rate, if grandma's physician follows these guidelines, she's got an absolute reduction in risk for death with CAP of about 10%. And you would have to treat, I think your data were, you'd have to treat, you don't say grandmothers, but you'd have to treat 10 grandmothers to save one, right?
Right. The editor said that.
Right.
That was a good point that he made in his paper about our data. So kind of wish I'd come up with that on my own, but it's a very practical way to look at that.
Yeah. Well, it's so the NNT is 10, as they say. So you need to treat only 10, which is a very good number. I think usually NNTs are, if you get something under, say, 25, or that's usually a good NNT, but yours is 10.
Right.
Dr. Fissman, your study involved more than 50,000 adult patients. Now, these are patients 18 and older,
right.
whose treatment had been compliant with the guidelines in about 2/3 of the cases.
Right.
What surprised you about your results?
Well, to be honest, what surprised us was this is not data that was purpose collected for a study like this. So we anticipated that there would be a degree of misclassification, both in terms of treatment, probably less in terms of outcome. If someone dies, that's a pretty hard outcome and is likely to make it into a quality improvement data set. But given that we anticipated some issues around data quality that would probably bias our study towards not finding an effect, what surprised us was how strong these effects were, how persistent they were as we adjusted for things like severity of illness, different geographic locations, community versus teaching hospitals, nursing home residents, and so on and so forth, underlying health conditions. So these were very, very, very robust effects, and they were very big effects as well, just like in Dr. Arnold's paper. These are strong effects, a relative reduction in risk of death on the order of about 30%. And what we found, I guess, in terms of added information relative to Dr. Arnold's paper, is because we had the luxury of looking at younger patients as well, we didn't really find age effects. So we're not talking about absolute reductions in mortality, but relative reductions in mortality. If you're a 30-year-old and you're admitted to hospital with community-acquired pneumonia, you're less likely to die than if you're an 80-year-old admitted to hospital with community-acquired pneumonia, whatever else happens. But the relative reduction in risk associated with your physicians treating you in a way that's compliant with the ATS IDSA guidelines wasn't actually different. So the relative reduction in risk was actually the same. So that was a bit of a surprise as well. So I'd say the major surprise was just how robust, how large the effects were, and how robust these findings were, given that this was a data set collected for a different purpose.
And Dr. Fissman, I think it was your paper that, or maybe it was Dr. Arnold, and if it was, forgive me, one of you characterized patients who had been overtreated, in other words, who'd been treated even more aggressively than the guidelines called for. When you looked at mortality in that group,
I think in terms of explicitly talking about overtreatment, which I think is brilliant, I think that was actually Dr. Arnold's paper. We touched on that indirectly, and I think our findings are similar. But the idea of explicitly looking at overtreatment, I'll pass that one over to Dr. Arnold.
Sure.
So Dr. Arnold, what's going on if you go even beyond the guidelines and treat more aggressively? What do you think is happening to increase mortality?
Possibly a couple things. The outcomes you would think would be the same, because a certain individual would have the same mortality or length of stay if they're overtreated, but it may be that these patients are experiencing secondary infections, such as Clostridium difficile colitis, that may keep them hospitalized longer and possibly even lead to death in some circumstances. We know with longer hospitalization, you're certainly at more risk for line infections and hospital-acquired pneumonia. So all those things have their own morbidity and mortality. Another reason that people may have worse outcomes who've been overtreated is that they're getting a more resistant pathogen or something like that.
Or they may have just been sicker to begin with, which is why they were overtreated.
They may have. Now, we controlled for that in our paper,
right.
But it may have been that two people had a certain comorbidity, possibly COPD, but one person had a more severe version, and we certainly didn't grade each comorbidity on a scale and try to control for that.
It just seemed an anomaly that, as I was reading those papers, people who got more treatment rather than less than suboptimal treatment. I guess you can't say it's super optimal treatment, but if you overtreated them, they didn't survive as well. I'd like to ask you both, why do you think about a third of patients weren't getting guideline-compliant treatment? As you mentioned, there were some guidelines available earlier, but even with that, about a third of the patients in both your studies never received guideline-compliant treatment. And what's happening there? Are these patients, clinicians following earlier guidelines, or do they think they have other theories about the best way to treat CAP?
Well, I have an answer, Forrest Arnold. Our study was international, and although the IDSA, ATS guidelines are generally accepted worldwide, individual countries have their own guidelines. And so those guidelines don't always require atypical coverage, especially in Europe. And so people may often get a beta-lactam in another country. Now, we're at a university setting and have a lot of control over the people that have pneumonia and their treatment, but I've noticed by working at the private practice institutions, the treatment is all over the place. And so there's another place where the independence of antimicrobial prescribing is akin to different regimens, and some including not covering atypicals. And then finally, in international countries, some places don't know that they have atypical pathogens because they don't have the resources to check them. They're called atypical because they're difficult to work up and they're not grown on the typical media. And so if you can't work up for atypical pathogens, you don't know that that bug is there, and hence you don't feel a need to cover for it.
Mm-hmm.
Yeah, I would just add, it's David Fissman. I would add that at the country level, you're likely to have differences. What's also interesting, and we really know this from our colleagues at Dartmouth who have been putting together atlases for the U.S. in terms of healthcare and healthcare outcomes, is that all healthcare is local. It's like politics. And you do tend to have a lot of local clustering of what are perceived to be best practices, which often relate to the strongly held beliefs or experience of local clinical opinion leaders. And so what may be perceived as best practice in one region may be at variance with guidelines promulgated by either national or international groups. That's not to say there's no value to local wisdom or local perceptions or local experiences. But I do think we're reaching a point where I don't know if Dr. Arnold is aware of any studies to date that show that complying with guidelines results in significantly worse outcomes. I believe that our two papers are actually the latest in a number of publications that have come out, all of which have unfortunately been observational, and we can perhaps get into that in a moment, but all of which have been extremely consistent in terms of, none of us are finding anything different here. What we're all finding is that when you comply with the guidelines, the patients do better, and at the end of the day, that's what this is all about. And I do know that individual clinicians may have strongly held beliefs or may have experiences that are at variance with guidelines. But in terms of the evidence available to us as we make decisions about how to treat patients, the evidence is sort of singing with one voice right now, and that tends to push us in a direction of saying, yes, compliance with these guidelines is actually very good for patients and probably very good for the healthcare system in a variety of ways as well.
I mean, there may be strongly held beliefs out there, but you've got the data. And the data, as you say, are singing with one voice. And between the two studies, you've covered maybe not all bases, but at least 2 out of 3 bases on the field. Are there still skeptics lurking out there who say, no, the research wasn't conducted in the proper way, or I still think that there are other ways to handle this? Certainly, nobody is saying, well, let's wait until the lab reports the results until we start treating people.
Oh, I'm sure there are. This is Forrest Arnold. Bradley Sharp's editorial was very complimentary of both of our manuscripts, and so that may be an invitation for several editors to the editor for us to answer it later, and I'm looking forward to them, frankly.
It would actually be fun if in that situation, sorry, I assume this will get edited out, but it would actually be fun to communicate about that, maybe even try to do a joint answer, if you like, because I wouldn't doubt that we may be in for that. But okay, back on the record.
Wait, do you really want me to edit that out? Because there's certainly nothing collusive about the fact that...
No, it's not collusive. I don't know,
I'm not trying to be confrontational.
Right.
Exactly.
No. I think it would be very interesting, and if you did get some of those letters, I think you should get in touch with me, and we'll have you back on, and we'll talk about this again.
I'm sure they're coming. It's very common for letters to the editor to disagree with the authors.
Yes.
We see that all the time. That's basically why you write a letter. You don't usually write a letter because you agree with somebody so much. Anyway, I have no problem publishing, but do what you want.
Can I just make one additional comment? It's David Fissman.
Sure.
Just to comment on the base that is uncovered in both of our studies and most of the studies to date, and that is a base that's very difficult to cover, which is the issue of clearly the difference between observational research and experimental research, like a randomized trial, is that we can use fancy statistical methodologies and adjust things up and down, but we both know, and our co-investigators know, that we can never say with 100% certainty that the differences between individuals receiving guideline concordant therapy and guideline non-concordant therapy weren't due to some other fundamental differences between those two groups that we failed to capture and failed to adjust for. In other words, what an epidemiologist would call residual confounding. And we can't honestly say with certainty that there is no residual confounding in either of our papers. That said, again, as Dr. Sharp pointed out in his editorial, these are strong, large, robust effects. So I think the onus would be on anyone who thinks that these are spurious effects. What they would need to do is identify the large confounder that we failed to take into account and identify the effect associated with such a confounder that would be so large that it would overwhelm the large protective effects that we're both identifying in our papers. So it would really need to be an elephant in the room confounder to negate the findings that we're identifying here. And I can't think of one. I don't know if Dr. Arnold can think of one. Dr. Sharp couldn't think of one either.
No, I can't. I do think a limitation that both of our papers share is that we have in common they're both retrospective. And really the only way to generate a prospective study would be to have a group that receives therapy according to the guidelines and one that does not. And obviously, no IRB is going to approve a study where somebody receives inferior to what the guidelines recommend.
Right.
And so it's a legitimate criticism, but it's one that I don't think we can get around.
Right.
Well, as a result of your data, the two of you, what do you think clinicians should be doing this week that they may not have been doing last week?
Dr. Fissman here. I think they should probably be brushing off those IDSA ATS guidelines and taking a look at the algorithms there and making sure that they're approximating those when they treat patients. I think one of the things that's so hard about this is that when people broaden out coverage clinically, or when they add an additional agent because they're concerned about an unusual pathogen or the possibility of resistance or what have you, they are acting in what they perceive to be the patient's best interest. They're being concerned clinicians. And I think it's very, very difficult to message this in terms of telling people, you may have concerns. Those scenarios that are in your mind are probably possibilities. And those are scenarios that are understood by the people writing the guidelines as well, who are also practicing clinicians. But right now, in the absence of specific, for example, data that push you to cover methicillin-resistant Staph aureus, or data that push you to cover resistant Pseudomonas in someone who's coming in with pneumonia, in the absence of data that actually make that decision for you, the bulk of the evidence right now says that it is safest, best for the patients, best for your healthcare institution in terms of length of stay and resources to stick with the guidelines until actual clinical information pushes you in a different direction.
This is Forrest Arnold. I would agree with that. People do need to dust off the guidelines, and some are legitimately intimidated by them. They're over 70 pages, but there is an executive summary in the beginning that really breaks down everything you need to know, and they can be followed much easier. The summary is just a few pages, and that may be what a lot of people can practically do this week that they weren't doing last week.
Okay, and I will post a copy of those guidelines. When we covered your papers in Physicians First Watch, we had them as part of the coverage, and I will post them on the website, podcasts.jwatch.org, and they will be there. So, Dr. Arnold and Dr. Fissman, thanks so much for your time today.
It's a pleasure. It was great to talk to you both.
Yeah, thank you.
Well, dear listeners, I want to ask you again, please go to the website podcasts.jwatch.org to fill in that survey. You'll be getting a $5 Amazon.com gift certificate, and who knows what you can find at Amazon for $5. You can reach us at 1-617-440-4374 with your help or suggestions, or you can write to me at jelia@nejm.org. If you want to listen to earlier podcasts, they're all available at the website podcasts.jwatch.org, where links for all stories can also be found. Clinical Conversations executive producer is Adore Yano, and I'm Joe Elia. Join us next week. Enough said.